Welcome to the Rehabilitation Science Group. Today we are here with a very interesting topic, maximizing vaginal birth outcomes with alternate birth position. For the lecture, we are having with us Dr. Latha Balasundaram. Dr. Latha, I would like to have your consent. We are going live on YouTube.
Sure, sir.
Dr. Latha is MPT in neurology in the adult and pediatric specialization. She is LAME certified childbirth educator. She is a pelvic floor specialist. Along with this, she is board certified lactation therapist. She is head of the physiotherapy at Fernandez Foundation Hospital, Hyderabad. We welcome you, Latha, on the Rehabilitation Science Group. You can start your lecture.
Thank you, sir. Thank you, Dr. Shagun. I'm honored to be a part of this group, and thank you for inviting me. This group is doing a great work by, especially in this time where digital media is of utmost importance. You all have got education across all over through these interesting topics across different areas of physiotherapy, and thank you for this opportunity. Yes. So today my topic is maximizing vaginal birth outcomes with alternate birth positions. This is mostly a physiotherapeutic approach. So how can a physiotherapist play a role with vaginal birth? It is not just limited to the scope of antenatal exercises or just postnatal treatment or exercises or weight loss or tummy toning, but there's a lot more that we can contribute and expand our scope of practice and create a niche for ourselves. So this is what I would like to brief through this lecture. I would first start with just a simple thought in your mind as to what is wrong with this image. Yes. So elephants are definitely not positioned this way, neither do they walk this way, neither do they birth this way. So when humans also don't walk this way, why are we forced to birth this way, right? So the most commonly used positions are what you see on the screen, which is lithotomy, where the mother is lying on the back and the legs are flexed, abducted and externally rotated, right? Or at the max, if there is, if there's an alternative, then it is reclined sitting where the bed end is not flat, but it's elevated and the mother is in a similar position. Remember, this is a position where it is on the sacrum. As you know, the sacrum is blocked and really there's not much mobility allowed in this position. Okay. Now, why has this position started to be in use if it is not the best position? Okay, we want to say, and a lot of obstetricians would definitely agree that on the back is not the best position. But why did it come into picture? It's when there was a shift to medicalized birth, like hospitalized birth. This is when the lithotomy position came into picture, right? Also, there's a cultural image of birth that we have in our minds, which is, through movies. You ask any young girl, how do you think a mother will birth? Or even pregnant mothers who come to our sessions and classes, how do you imagine birth? They will say, we imagine it on our back, right? So this is what our movies and the impact that television has on us and our minds. There is ease of intervention or monitoring that we call, because when on the back, you can do continuous fetal monitoring for the babies easier without movement. And there is also a lot of comfort and convenience in mothers being in this position. The obstetrician can check the pelvic dilation, the cervical dilation. The mother can do an internal examination if the doctor wants to do any procedures like episiotomy or anything else, or even birthing the baby. There's lack of training where we don't think being in any alternate position is very common and easy to birth. Okay. Now, how from biomechanical point of view, we need to consider a few things for birth. One is, you see that the anterior posterior diameter of the pelvic outlet increases obviously when the sacrum moves out, right? And similarly, the side to side diameter increases more during internal rotation of the hip. So as you can see the image here, this is a peanut ball which is used in birth. Suppose a mother can't move around and has taken epidural multiple doses. This could be a ball which gives a nice supported sitting and alternate posture to the mother, where the sacrum is free. Definitely mother is not on the back, but when you see the hip, if you look at the hip, here it is internal rotation. The ischial spines are going away from each other, but when the hip is externally rotated, they are moving closer to each other. And we know that we want a pelvic outlet that is wider for the birth of the baby. Now, looking a little more in detail, there is anterior tilting of ilium, which increases the diameter of the pelvic inlet and therefore facilitates the descent of the baby into the pelvis, okay, and obviously counternutation of the sacrum. But when it comes to posterior tilting of the ilium, there is the opposite effect, which is increasing in the diameter of the pelvic outlet, therefore facilitating the easier birth of the baby. Now, hip extension favors descent into the pelvis, whereas hip flexion favors birthing of the baby. Now, keeping these simple things in mind, you can see very clearly here as the sacrum moves out, the ilium moves in front, the diameter is increasing. Here the outlet increases and inlet closes, and subsequently the opposite effect when the sacrum comes closer or is blocked, the inlet actually opens out, but the outlet actually narrows. Okay. Now, why alternate positions? So you see the both the purposes of anterior posterior as well as the lateral side to side diameter opening up is not really facilitated by lithotomy or the recline sitting being the ideal positions. So what do we conclude? We conclude that birthing of the baby is not made easier for the baby. It's made easier for the care provider, right? So if we are going to look at it being easier for the baby and easier for the mother as well, because there's more effort when the mother is on the back. She's birthing, pushing, bearing down against gravity, whereas gravity is working downwards. That is one. Obviously, there's more exhaustion for the mother. There's more distress for the baby as well, because there's more chances of compression of the inferior vena cava, the cardiac aorta, therefore causing maybe more chances of distress. And obviously, when you're using so much effort for such a long time against gravity, there is more chances of perineal damage. So what alternate positions can we offer and what are our reasoning for it? Okay. The alternate birth positions that we can offer are off the sacrum, mainly to increase the AP diameter so that the sacrum can move out effectively in increasing the pelvic outlet. So side lying is one of a position. If a mother chooses to be in sideline and feels comfortable, then she can be in sideline. Some mothers can also, most mothers actually love to opt for hands and knees or quadrupod or all fours position. A lot of them may prefer kneeling and alternatives to kneeling like kneel lunge or kneel and forward leaning. Some also birth in squat. This could be a deep squat or a supported squat. Now, why we need to have so many variations is you have to give plenty of options for the mother, which are biomechanically right for her, but at the same time give her the option of choosing what is right and what her body is allowing her to do, because her baby is going to be her guide and we can't predict that, right? So we have to prepare them in all these positions. Now, as you can see, if it is difficult for the mother to be in one position unsupported, obviously this is a peanut ball where you can be in supported and be in the sideline. Now, hands and knees, yes, you can't take so much weight on your shoulders and hands throughout, and it may be stressful. Therefore, you have tools like the comfortable upright birth. This is like an inflatable chair sort of a thing. It is called a cub. And here you have a birth ball. As you can see, both can be used for the same effect. Now, kneeling. Now, again, like because labors can be long, mothers can be exhausted, there may be less, energy. They may not feel so up to doing a lot of movement. So you can use tools like this cloth, which we call as rebozo, to hang. When you hang in kneeling or kneel lunge, what happens is obviously the trunk musculature elongates, making more room for the baby to maneuver its way down. And also hanging sort of has lesser effort from the mother's perspective, right? Because she's leaving her body free. And again, when you hang, you balance the pelvic girdle better, the sacral out, movement, and there's no restriction from any area in terms of the bed or anything else. Okay. Then you have a deep squat. Now, a deep squat, as you can see, is the first image. And suppose, yes, the mother has issues, knee pain, some surgery, is not comfortable in being in a deep squat throughout. A lot of mothers are not comfortable in that position throughout. Then you can be in a supported squat, like this is a birth stool, where you have the same advantage of a squat, but at the same time, because squat increases the pelvic diameter by outlet diameter by around 25% more than obviously on the back. You can use a birth stool. So you have plenty of tools which can help mothers to be in these alternate birth positions. Okay, and the birth ball, you have different sizes. We have like 55, 65, and 75 centimeters based on the height of the mother, which can be comfortable for her. You also have the peanut ball. Peanut ball, like I showed you, you can use it in sideline. You can use it for sitting as well. You can use it for relaxing in all fours. This also is in different sizes for the according to the height. If you don't have those tools, you can always use pillows to, do the same for support, or you could use a birth stool. Then you also have, like I told you, the cub. Many positions you will be seeing on the cub that we do, and also a rebozo, which can be used for hanging to facilitate maybe neutral spine in certain conditions which we are going to see, or to even support the mother and decrease her load of work through labor. Okay. Now, specific conditions of birth positions can be given in many conditions, like we've given mothers specific alternate birth positions for mothers who've had polio. We've given for mothers who've had, hemiparesis. We've given birth positions for mothers who have multiple sclerosis. We've given for acute pains. We've given for pelvic girdle dysfunctions. We've given for pubic symphysitis or pubic diastasis, pubic recti, sorry, or musculoskeletal problems. And when we come to musculoskeletal problems, today I'm going to address only on 4 musculoskeletal problems. I have 4 conditions basically. One is avascular necrosis of hip, which commonly directly they go for a C-section. Coccydynia or pubic diastasis, which causes severe pelvic girdle pain, and mothers, when they come with that, they are so distressed through pregnancy that they themselves actually opt for a, I can't go through birth. They start to worry if they can have a normal vaginal birth. And so do obstetricians come in that, frame of mind. And this is where we want to, or even if the mother goes ahead having a normal vaginal birth, the postpartum period can be very distressing for these mothers. I have seen mothers who have given up on breastfeeding because they were unable to sit postpartum fit to feed their babies, and it causes a lot of mental, emotional, and physical trauma for them. Now, a condition like pot spine leading to a discogenic problem, normally when there is people say, I have back pain, I have disc problems, they definitely don't think they can have a vaginal birth. So this is another condition. And in perineal pain or severe, urinary incontinence, where they've had a previous experience, they've had long-term urinary incontinence, and post that they are apprehensive, they are fearful, and they don't want to worsen the pre-existing condition or have the same experience the next time. So we are going to address these 4 conditions. Now, the first case that we're talking about is avascular necrosis of hip post fracture. This mother had a history of fall from a tree and leading to a fractured neck in 2009. Okay, conservative management failed, and therefore internal fixation was done. Why was it done? Because there was still remnant pain that the mother was experiencing. And when they did a X-ray, they realized that it is not healed, and they need to do internal fixation. And that is when they noticed that there is AVN of the right femoral head. There was decreased mineralization as well as reduced space. Okay, that is, I don't have very clear x-rays, but yes, as you can see, this is on the right side is where you can see the irregularities, you can see the demineralization, and you can also see the decreased space, right? Now on examination, this mother came to us early, in 20 weeks she came to us. There was restriction in the rotators, definitely hip rotators were restricted, hip extensors were restricted, and abductors were restricted. There were free flexors and adductors, okay? Along with that, she had severe, because it was a long-term condition, she had stopped doing a lot of activities. She had a lot of pelvic floor weakness. Therefore, urinary incontinence was significant in this mother. Tight lower back muscles, weak gluteal muscles, tight IT band, and multiple triggers on the gluteal area. She also had minimal of 1 centimeter LLD shorter on the right side. Now, I'm just giving you gists of what her clinical condition was, so that the focus of management. Our focus of management was obviously improve flexibility in the lower back, improved strength, improve strength, improve flexibility. Now, if you don't manage the pain for these mothers, they are not going to be compliant in coming repeatedly for follow-up sessions. And then if you don't have follow-up sessions, there's no way you can help them through intrapartum and postpartum, right? So therefore, our primary goal and focus for all these mothers who have specific conditions is primarily pain management, okay? So we used, TENS for her pain management. We also used a lot of trigger release to improve her flexibility. There's a lot of radiating pain because of the gluteal triggers which she was experiencing. We worked on the core strength to reduce the stress on the hip joint. So we worked on all these areas, rehabilitated her through pelvic floor rehabilitation. We also worked on flexibility aspect because you know how crucial rotators are in the contributing to the pelvic outlet diameter. So, and apart from working in all these areas through successive visits, we don't call them every day also, maybe every trimester we would call them once or twice depending on the condition. We worked on orienting them functionally and positionally for outcomes in labor. Now, whatever alternate positions you're giving them, it should not be that for the first time they are going to do it in labor, right? It's not possible to maintain a position for so long. So while rehabilitating them through the muscle balance, whether it's flexibility or strength, all your techniques that you can use, your soft tissue relief techniques, your strengthening techniques, your core stability techniques, then you're also going to re-educate them for the positions that you are going to give them in labor. Now, for this mother, birth position suggested was sideline with the peanut ball. So any upright position basically, but what we had to keep in mind here was knee lunge, what I had shown you, that knee lunge had to be done with the left leg out because the right leg did not have so much of the flexibility and we didn't want it to load too much for the strain to be taken by the right leg. So right hip. So therefore knee lunge, if she had to do, we had to give the left leg out, not the right. Obviously hands and knees was a comfortable position. Kneeling would be a comfortable position. And in case she needed any assisted vaginal birth procedure, then we would recommend reclined sitting for a limited period of time, usually 10-15 minutes it is done. So these were the birth positions suggested for the mother. And like I said, we did not encourage the right to be in rotation and flexion and component, abduction component. Next, we wanted to specify to avoid lithotomy for obvious reasons. Lithotomy has and deep unsupported squat, because the rationale being there's more compression on the femoral nerve, more neuropathies, more nerve injuries with the rotation, abduction and flexion component, and more so there was functional restriction for this mother to be in that position. So we opted for these and we suggested these, and the mother opted for reclined sitting due to the need for having a kiwi or the assisted vaginal birth. So these were the suggestions made because frequent changing of positions, because she was not able to sustain one position for too long. So any upright position which required, swaying of the hips or sitting on the birth ball or all fours on the birth ball support. All these were suggested to frequently change. That's why we had to give a lot of options, so that every 45 minutes or 1 hour or so, she was encouraged to move and change the position. The rationale being obviously based on her functional and positional retraining in antenatal period. Now, what was the intrapartum details? This mother set into labor spontaneously. She had multiple doses of epidural and therefore needed, I guess, needed the vacuum delivery. And she did have episiotomy. And because she needed that procedure, she was in recline sitting. Okay. Now, what was the postpartum follow-up? It was relatively uneventful. She didn't have much pain or anything. She was taught the necessary exercises. Because she had an episiotomy, there was a 3-week delay in doing the regular exercises, but early pelvic floor and core activation was suggested. Definitely do's and don'ts were given to her, and ergonomic retraining was given to take care of her baby and feeding procedures. Now, do's and don'ts involved mostly any floor level activities were restricted for this mother. Obviously, Indian toilet was restricted for this mother for some time, and also excessive stair climbing if she had to. These were her simple restrictions that were given to her. Now, the second condition I would be talking about is coccydynia. And with coccydynia, this mother had severe pelvic girdle pain. Now, this mother was a fourth gravida. So, she had 2 previous vaginal births and 1 C-section. Okay. Now, she had a history of fall on her buttocks 2 years ago and was not very keen on the vaginal birth. Okay. The previous mother was very keen and she was very young. So, she was very compliant. This mother wasn't that compliant and she really wasn't very keen, maybe because of her past experiences. As you can see, she had mild diastasis pubis, therefore she had severe pubic pain. She also had anterior translation of the coccyx segment with anterior angulation. Now this mother, because she had multiple births and she felt she was really in a lot of pain, she didn't really want to give a try for a vaginal birth, but her husband was very keen. So on examination, tenderness along the T12 to coccyx area was present. What was important was her Fabers was negative bilaterally initially, but she had extremely tight hamstrings. Just SLR was 45 degrees. She had a lot of suprapubic tenderness. Pain developed after the 28 weeks, which was coinciding with her diastasis pubis that we see. She had soreness and triggers in bilateral glutes, and she had severe vitamin D deficiency. Now, mothers who have severe vitamin D deficiencies also are very prone to these kind of pelvic girdle pains. A little higher inclination is seen in these mothers. So our focus of management was to strengthen the posterior sling muscles and pelvic stability. Pelvic stability exercises definitely. A lot of release for those gluteal triggers. We needed to improve the mobility of the sacrotuberous and sacrospinous ligaments, contributing to the injury for the coccyx. We didn't want that to be restricted because of tightness in that area. So we worked on releasing those. We worked on the flexibility of a psoas, all of that. But we had to keep in mind 2 things here. One is, apart from improving flexibility with whatever her pre-existing injury was, we could not do a lot of flexibility because of a pubis gap that she had, diastasis pubis that she had. So we had to be very careful in balancing flexibility and strength for her. And definitely we had to give her, refer her for her vitamin D deficiencies. Her level was 6, which is extremely deficient, and she was on simultaneous shots for that. Now, what birth positions were supported? We didn't give too many because we knew that the mother wasn't very keen on doing a lot of effort in labor, but we did give her what was recommended for her through her pathomechanics and biomechanics, which is side lying, all fours, kneeling, and definitely hydrotherapy was advised. Now, why hydrotherapy was advised is, we have seen that, and research also, evidence also suggests that hydrotherapy helps a lot with pelvic girdle pains and helps in generally reducing pain and better pain management and coping strategies because of the warmth of the water, number one. The water takes away 70% of the body weight. So there's ease of movement and also lesser strain and stress on the joints. So the pelvic girdle per se in this mother. And they would have definitely faster progress. Okay. These were the ones that were suggested for this mother. As you can see, this is our birth pool we have. This is a mother in the birth pool. You can acquire any position in the birth pool. This is sideline with peanut ball. This is all fours and this is kneel. We did not want to give any asymmetrical position like a kneel lunge or anything like that, because again, because of the, you can see already the gap between the pubis diastasis which is there, and we did not want to cause any asymmetrical rotation and those kind of components which will worsen her postnatal period experience. Now when we see what to avoid, we did want her to avoid reclined sitting for obvious reasons. There's more strain on the coccyx, the sacrum, and it would be blocked and there's more effort. So obviously postpartum would be terrible if we would have gone ahead with that. Lithotomy, for reasons that it would cause, and full squat, both for the same reasons, that there is rationale of more trauma to the tailbone because of the block in on the sacrum in reclined sitting, and lithotomy and squat because obviously there's more stretch on the pubic symphysis, which we didn't want to worsen her diastasis condition. Okay. Now, what did she opt for? She opted for lateral, left lateral, which is the left sideline position is what she opted for. What happened in intrapartum? This mother, because she was G4, she said, so this mother wanted a C-section. Obstetrician sent her to us to manage her pain and to see if she can have a vaginal birth. We gave our feedback. Both of us agreed she can have if she wants to, but she opted not to. So she was scheduled for a C-section. But still we had to see, we do this, we saw her through antenatal period, followed up all of that just in case. Now, just in case was good because before her date of C-section was set, she went into spontaneous labor because she was G4. And she opted that she will go ahead, and because she set into spontaneous labor, she said, okay, I will go ahead for a vaginal birth. So the option was given to the mother and we managed her nonetheless. Now, anesthesia, she did take epidural. She had a very spontaneous vaginal birth. She had an intact perium, no episiotomy, no vaginal tears, because she was multigravida. Postpartum, she did have pain, but to much lesser degree. She was taught exercises to follow immediately, core and pelvic floor activation. And because she didn't have any perineal tears, she was free to do progression of exercises also without a timeline. Don'ts were definitely given, and a pelvic support belt was given for this mother for at least 3 weeks, just as a precautionary measure for her pelvic girdle pain. Now, the third condition I would like to talk about is spot spine with listhesis and disc bulge. Okay. Now, this was a mother who was a primey. This mother was very keen on a normal vaginal birth. She had a history of pot spine in 2014. She was on medication. She finished everything. She had a flare up of the discogenic back pain in 2017. Now, on and off, this mother would experience pain, but only on strenuous activity. And when she rested, she would be okay. All right. Now, she was a young mother, she was a student, so she was also very compliant. On examination, there was her MRI findings were there were early degenerative changes in the spine. There was listhesis of L4 over L5, grade 1. There was disc desiccation at L4, L5, and S1 levels. And there was a broad annular disc bulge with broad-based herniation at L4, L5, and L5, S1. Because this was a lower lumbosacral discogenic pain, we had to assess her obviously for any cauda equina symptoms. Any of those proper neurological examination was done before we could even think of going ahead with a vaginal birth for this mother. On examination, yes, she did come in with pain. SLR was positive on the first visit at 24 weeks. But following successive visits, her pain reduced drastically. She was very compliant. And immediately before birth, when we reassessed them for birth positions, she had a negative SLR, she had negative Fabers, she had negative slumps as well. But she was still unable to lie on the back for more than 15 minutes. And then her pain definitely triggered in hands and knees position, or any forward position, forward lean position for that matter. For more than 10-15 minutes, she was getting the trigger of pain. So in this, our focus of management was primarily to improve her core stability. So we focused on neutral spine with proximal and distal segment strengthening. So we did a lot. Her posture had changed because of the long standing condition that she had. So we worked on her upper back. We worked on her, hip and knee and flexibility component, strength component. And most importantly for this mother was retraining breathing awareness in labor. We will know, or you will see in the next slides what exactly why we did that, and working on orienting functional and postural outcomes. Now, because any forward lean was uncomfortable for this mother, we had to ensure that strictly neutral spine was to be maintained for this mother through birth. Okay. Now, birth position suggested because of this was any upright birth position with a neutral spine, avoiding all fours because it was a L5 S1 and we don't want that to be aggravated. So we said side lying, birth stool, which is on the birth stool supported squat, kneeling with neutral spine, knee lunge with neutral spine, and a rationale for using rebozo. Like you saw, the rebozo is a cloth which pulls, right? Which you can pull, push, use for support, all of that in labor. Now, the rationale for using rebozo was when you pull on a rebozo, number one, bearing down the baby is easier. And when you pull on a rebozo, the avoidance of spinal flexion is more in check. That means we can ensure neutral spine for these mothers, and there's a lot more activation of the stabilizers of the lumbar area, and that is why rebozo can be used in these kind of conditions, and specified that a neutral spine should be followed. Now, even like if you use a rebozo on top and you hang, you're obviously ensuring you're not forward leading. If you're using a rebozo in side lying or any position for that matter, where you place the rebozo to facilitate spinal neutral or extension will be easily achieved than not using a rebozo. Okay. Now, birth positions that we suggested were all these, and you can see the rebozo being used in all of them. Uh, Left or right knee lunge could be done, squat. In this, in any of these positions, I would like to say that keeping the feet wider than the knees, facilitates a wider pelvic outlet. So that can, if there is difficulty for the baby to be born or it's stuck or anything, then you can use that tip to help the pelvic outlet diameter increase. Now, birth positions avoided was reclined sitting, obviously, because when you recline sitting, you pull the knees up and you're in flexed posture and you do the bearing down, which is a lot of effort, and obviously intradiscal pressure and posterior bulge would worsen. Hands and knees, because it was a lower lumbosacral discogenic issue, we did not want to use that. Unsupported deep squat, because when you are unsupported deep squat, you use a lot of spinal flexion. You know that when you are bearing down, your tendency is to go in for a spinal flexion, which again would worsen the posterior disc bulge component, and any forward leaning position for that matter, only in bearing down. Now, I'm not saying don't use, and she could use any other position for intermittent transition in stage 1 of labor. But we are talking about stage 2 of labor, where any forward lean and effort to bear down should have been avoided. Now, rationale being obviously forward bending with effort increases intradiscal pressure and increased chances of worsening the posterior bulge that she had. What did the mother opt for? She opted for kneeling and stressing on the neutral spine. What were the suggestions we gave in labor for breathing retraining? Like I specified, is in stage 1, the mother, basically the rationale is to avoid Valsalva maneuver, because as widely known, Valsalva maneuver can widely increase. Studies have shown capillary bursts in the eye, has shown a lot of more increase in the intradiscal pressure, more effort. So all of this you want to avoid. And therefore, we would research has shown that 7 seconds during the phase of bearing down, when the mother has the urge to bear down and she's having a contraction, instead of holding your breath for a long duration of time, 7 seconds repeatedly through bearing down, that too not holding your breath, but using a partially closed epiglottis breathing, like a, where you're partially closing it and yet vocalizing, that has shown lesser damage in all these aspects. So what this was a suggestion for breathing retraining, and the mother had to retrain and practice slow breathing consciously every night. A few weeks before her labor, she had to practice the partially closed epiglottis breathing as well. But we would ask her to practice it when she was on the toilet seat rather, because bearing down is compared to that. So we suggested that for the mother. Change of positions every 45 minutes, because any static position for too long was uncomfortable for this mother. And rhythmic breathing with rhythmic movements like hip sways in any resting position was suggested. So the rationale being, longer breath holds has increased chances of damage in discogenic conditions, and also more perineal damage and more distress to the baby. So basically avoid Valsalva. What were the intrapartum details here? This mother had a spontaneous labor. She did not take any epidural or any analgesia, and she did not have even an episiotomy. She only had a grade 1 perineal tear. Now, postpartum, this mother had mild pain only while feeding the baby. Okay, because obviously because of the ergonomic, if it is not met, she was, that's why, asked to wear a lumbar and abdominal belt for 3 weeks to support her back to be upright a little more. Feeding and ADL ergonomics were taught to this mother, and exercises were taught. Early activation of pelvic floor and core was definitely taught, and after 3 weeks the progression also was taught to this mother. Okay. And the last condition I would like to discuss is perineal pain with stress incontinence. Now, this was a mother who was G3. She had a previous history of episiotomy in previous birth. Sorry, she was this was a second pregnancy and birth. She suffered severe perineal pain post-birth. So it was a very traumatic perineal pain experience for this mother. She suffered stress urinary incontinence in postnatal period in previous birth, and also in the present pregnancy. Early on, by around the 3rd month itself, she was experiencing stress urinary incontinence. Now, on examination, there was tenderness over the perineal area, more on to the right. There was no tenderness or swelling in suprapubic region. This signifying that it may not be a pubic, symphysitis pain or diastasis pubis rather. It could be also that the mother had, because of the multiple gluteal triggers she had, it could be a referred pain also to her pubic area that she could have been experiencing. She had a weak pelvic floor with, as already said, stress incontinence, and she definitely did have more significant tightness in her psoas, in her adductors and perineal muscles. It could be because of the previous episiotomies that she had some triggers in the perineal muscles. SLR and Faber's was negative for this mother. 1 second. But this mother did have a lot of fear of episiotomies and vaginal births. So this mother did not want vaginal births through, vaginal examinations through her birth. She did not want that. So she opted for no vaginal examinations in her birth preferences. And she definitely did everything to avoid episiotomies. So focus of management for us was to relieve the perineal triggers. So we did advise warmth and perineal massage in the last few weeks of her pregnancy. So at least 3 to 5 weeks before her EDD, we always we suggest and we teach them how to do a perineal massage. We also rehabilitated this mother through the pregnancy. She was rehabilitated in the correct way to activate her Kegels. in supine, in sitting on the ball, all fours, in standing on the Bosu ball, on unstable surfaces. So pelvic floor rehabilitation was our primary focus because of the urinary incontinence episodes she had in early pregnancy, which responded very well, and she didn't really continue to have any after almost 6 weeks of retraining her. Relieve the multiple gluteal triggers. Like I said, if you don't manage the pain, these mothers will not comply with you and not come for follow-ups. So our focus was to relieve the gluteal triggers that could be contributing to the radiating perineal pain. We improved her psoas, adductor and perineal flexibility by giving her sideline releases, dynamic stretches, and hold relax techniques to improve the flexibility. We maintained balance of pelvic stability and flexibility for this mother, and reinforced on breathing awareness. Again, if this mother would do the same Valsalva maneuver for birthing her baby, obviously there are going to be more chances of perineal damage for her, and she already has a history of stress incontinence. So we had to focus on reinforcing the breathing awareness, pelvic relaxation, because when a mother comes to you with the fear of vaginal examinations, fear of episiotomies, these kind of things, they are generally, very, they hold back and they hold very tight when the pressure of the baby is felt in birthing, right? So relaxing the pelvic floor, obviously when you're having a tense pelvic floor and trying to birth your baby, you're going to lead to more perineal damage. So enabling this mother to relax the pelvic floor also had to be taught. So she was given a lot of sessions of mindfulness and practicing relaxation voluntarily, doing the perineal massage, doing the practicing the breathing retraining, and environment modification was done for her in labor, which is dim lighting, soothing music, her partner of choice that she had in labor, so that, and no vaginal examinations. Hydrotherapy or warm perineal pack also was suggested, as I'll show you. So the birth position suggested was any upright position, heels wider than the knees, because like I said, we are looking at the pelvic floor, so we wanted the diameter, in that sense, the bone to have to be wider. All fours, birth stool, sidelines, kneeling. We didn't want a full unsupported squat because of more chances of perineal tears. Sometimes they can be very fast, mother's uncomfortable with that pressure and then she holds back. So chances are also, I mean, research also shows more chances of perineal tests in squatting as compared to side lying or all fours, and therefore we did not give that option, but definitely supported squat was given because the perineal adductors, all those areas are supported, and therefore tension is much lesser in those areas. Now, what had to be avoided was, I already said, a full deep squat for reasons. Lithotomy, because effort of the mother is against gravity, obviously more risk of perineal tears. The pelvic outlet also is blocked more because of lack of mobility for sacrum. So obviously that also could have increased risk of more perineal damage, is seen with the above positions. Now the birth position opted by this mother was all fours, hands and knees. Now, suggestions, again, we did the same breathing retraining for this mother, 7 seconds repeatedly, partially closed epiglottis breathing. She practiced a lot of vocalization and humming again on the pot. She did a lot of frequently changed positions. She used hydrotherapy for pain relief. She did have, suggested was warm compress, but because she used hydrotherapy, which is kept at a temperature of, 97, 98 degrees. The warmth already did relax the mother's perineum muscles, and focus was on rhythmic breathing and rhythmic movement to promote relaxation, and obviously techniques like visualization and environment modification, aromatherapy, music was used for this mother. Now, intrapartum details. This mother did have a spontaneous set into labor spontaneously. She did not take epidural. She did not have an episiotomy. She did have only a grade 1 perineal tear with resuturing, with suturing. Postpartum, she had very mild perineal pain for 2 weeks. Again, Natural tears heal faster because they are more vascularized. They have lesser pain. Whereas episiotomies are external, they cut through the layers, and therefore the pain is more, healing also takes longer. So this mother had an advantage of the internal tears rather than episiotomies. She did not experience any urinary incontinence post the birth. Do's and don'ts were explained to her, which are primarily the suture care, taking sitz bath frequently, sitting in the tub of warm water multiple times a day so that the pain is relieved. And she also, perineal care was advised for her, and ergonomic measures for sure, and early and often using her pelvic floor and core muscles for core stability to continue for this mother, and progression after 3 weeks. So what does really evidence and the advantage of upright births show? Obviously, you're using gravity, and this gravity helps bring baby down. Therefore, it's shown to have relatively shorter labors if labor is progressing well, right? Shorter labors in stage 1 of labor has shown to be shorter by at least 90 minutes, right? And in stage 2, not much of a difference, but relatively shorter births. There's better oxygenation to the baby because there's no compression to the vena cava. Therefore, lesser distress to the baby. Chances of distress and going in for an emergency C-section definitely are lesser. Effective working of uterus, because the uterus is working, and the work of the uterus is to bring your baby down, right? And to position your baby correctly. That's why the uterus is working. So when you're using gravity and movement for these, you're optimizing the work of the uterus, and therefore better fetal positioning is experienced. Now, increased pelvic outlet diameter. There's lesser perineal injuries and need for episiotomy because upright positions, you're using gravity. Whereas when you're on your back, the diameter of the pelvic outlet is lesser. Your effort is against gravity. Therefore, more damage, more chances of perineal damage and need for episiotomies are seen. There's reduced need for medical interventions. Now, let's say mother is using upright positions, she's moving. Obviously, because of all that movement, the baby's position, the baby's head position, the descent into the pelvic pelvis is all much better rather than not having movement, right? So if the progress is better, then there's no need for medical intervention. Suppose the position of the baby is not right, there's less progress, there's less descent, then there's more need for medical intervention like augmentation or using Pitocin or any of these other successive breaking of the sac, rupture of membrane and so on and so forth. So need of reduced medical intervention is seen. There's reduced need for assisted vaginal birth, so vacuum, forceps are seen lesser use, and there's definitely an overall better birth experience and satisfaction for these mothers, okay, because they feel more in control of their birth. Now, what is the advantage of specific birth positions? The advantage of specific birth positions, like we saw in these 4 conditions, are the work of labor is brought down because again you're using gravity to its advantage. There's better mechanical advantage for the baby to be birthed, as we have seen. There's definitely increased pelvic outlet diameter. The balance, now we have seen in an initial few slides all the biomechanical considerations. So we have biomechanical considerations, and we can't ignore the pathomechanics of a particular condition that the mother has. So when you see a mother through antenatal and suggest birth positions, you strike a balance of that biomechanics and pathomechanics, which to the best outcome of the mother and baby. Okay, there's better functional outcome post birth to take care of themselves and the baby. Like, for example, I've given you, a lot of mothers give up on breastfeeding, taking care of their baby more actively that they wish to, because of their postnatal experience of how much pain they are experiencing, right? Suppose we go in for a lithotomy for a mother who has coccydynia or severe pelvic girdle pain or pubis diastasis, or we are going to go in for the same in discal problems and not retraining in for breathing techniques, then obviously their postpartum period is going to be not uneventful. It's going to be definitely with more pain. Therefore, the ability to take care of themselves and the baby affects them not just physically but also mentally. Okay, and therefore there is a better maternal birth experience and overall satisfaction for the mother. Now, to enable this, I know how we are in how our model of work is, and our scope for physiotherapists in general is. I may not have been able to do, or our birth team or our physiotherapy team may not have been able to do any of this if a model of care wasn't in place. And that is why I think as physios we should also have an influence on the model of care that is being practiced. That is, get early referrals from obstetricians or midwives or whoever is referring, the primary care provider is. You need to see them early to understand, to rehabilitate, and then help them and support them. We have to work on pain management first, because if we don't work on pain management, no mother will be convinced that exercise is going to benefit them unless you work on pain management, right? You have to work on body balance, because a lot of these conditions, there may be asymmetrical pelvis, which in pelvic girdle pains and in other conditions, which may have subsequent effects on the soft tissue like the ligaments or the muscles. So we have to specifically work on body balance. That is not only yoga and flexibility, but we have to work on a balance of what some mothers may need more strength, some mothers may need more flexibility. Some mothers have always done yoga, they may be over flexible, and those mothers may have more pelvic girdle issues because of the effect of relaxin as well, which again adds on to it. So you need those mothers will not need any yoga stretches, they may need more stability exercises and core activation. So that specific body balance should be there. Functional and positional rehabilitation has to be there, because like I said, it can't be that the mother is doing certain activities or positions only in the intrapartum period. She has to be rehabilitated through it. And even if she's doing it only in the intrapartum period, we should not ignore the fact that postpartum she may have more strain. So we have to ensure that we rehabilitate them through that. And then encourage definitely childbirth classes, because informational support and coping strategies improve the mother's confidence. And when their confidence is improved, they have a more positive outlook, saying that I can do this, And therefore, when give the mother the information, the mother has to discuss the birth preferences with the care provider. Now you may say the obstetrician will not support it, or they may not support it, but WHO has given clear guidelines that every mother should be given an option of, it is a birthright of the mother to opt in whatever birth position they want to opt for. Second is, they should be given freedom of movement. Okay, that has to be. You can't have a mother birthing and say you can't move and you have to be restricted to bed. No, that is not a law anymore. I mean, that is a birthright of the mother who's going to be a mother, that she gets to have freedom of movement. She gets a birth partner of her choice in the labor room. She has freedom of mobility and the freedom to choose her birth positions according to how her baby guides her or her body guides her. So she should be allowed to eat and drink. This is another, WHO guideline. So all these are rights of a birthing mother. So when you know the rights, only then can you demand that you need those things, right? So you need to discuss these birth preferences with whoever the primary care provider is. Now, whatever you see the mother in antenatal period, you have to also ensure that there is a practice of the intrapartum exercises that she is going to do. Birth positions, options, and breathing awareness should be practiced in the last few weeks, specific to the mother's condition. Now, all this cannot be successfully carried out if what you are telling and suggesting is not carried out by a midwife or an intrapartum nurse or an obstetrician who supports it. So you have to ensure that if you are planning all these things for a mother, the birth team, who is the intrapartum nurse or the obstetrician or whoever is there on call, also knows about these different options. So if you need to be educating them or opening their views about these things, you should be the one to be doing it. Now, after doing all this, you have to have follow-ups with the mother post-birth early. You have to advise do's and don'ts, because for a lot of mothers, when they don't know that they should restrict stair climbing, and they do it multiple times because they had a normal vaginal birth, they come back to the hospital with inability to move because of their PGP. Until then, they were fine. So you have to give these do's and don'ts to them. You have to tell them when they can bend, when they can stair climb, when they can sit on the floor to do regular activities, when they can cross leg, when they can use an Indian toilet position. All of this. Ergonomics for regular ADLs and baby care ADLs have to be done, because not all mothers will have support at home, and especially in this corona time, you can't call all the support you may wish to have. So re-educating them on their ADLs and baby care also is important. So these are how you can have the best outcomes in conclusion. Now, in the year 2019, we have seen as a physiotherapy team, a department in Fernandez Foundation, total of 125 mothers who were recommended birth positions in the year of 2019 for various challenging and painful musculoskeletal. Post-surgical, we have seen mothers who have had scoliosis corrective surgeries and who have a lot of internal fixation in their spines. We have seen those kind of mothers, musculoskeletal problems, neuromuscular problems, polio, like I've said, or multiple sclerosis, or any of these, hemiparesis. We have seen mothers following these conditions as well. So out of these 125 mothers, 79 mothers have gone ahead to have a successful vaginal birth, which is close to 65%, and the other 35% um, either decided not to go for not to go for a vaginal birth and went for a C-section, or either attempted vaginal birth but had to go in for a C-section. So this has been the statistics of 2019, and these are some of your references. Thank you so much. Dr. Shagun, I'm done with the session.
Yeah, thank you,
Yeah.
Ms. Latha. And it was wonderful to hear the talk, not only because it is something new for us, but also because you have told some very important aspects of the role of physiotherapist in the intrapartum period. And when you talk about outcomes, you talk about a better birth experience.
Experience, yes.
Right. So a lot of times we are discussing about how much was the pain,
Hmm.
how long was the duration of partum, and we are talking in terms of finding out objective measures, whereas life
Yes,
is not measured objectively. So experience matters, and I
yes,
think if we make that better, I think a lot of females are just scared of birthing, and they opt for cesarean section just for the
yes,
reason of the experience of birthing. And if we are able to make that better, I think uh, a lot of postpartum complications can be avoided.
yes,
So a lot of things were new for us, and the good part was that the four cases you explained relating the pathological with the biomechanics of labor. So I think there is a lot to take away from this lecture. And lastly, the good thing of the lecture was uh, the the uh, the lady has the choice.
yes.
uh, so you give the option, and
Hmm.
I don't know, I have seen many institutions which offer that choice. So this practice has to be started, and the option of not only the partner who can be with the lady, even the position and all the practices in and around that partum should be with the person. uh,
Yes.
Lata, I just wanted to ask you, how do you take that decision is very important about the position. You said you mix the biomechanics with pathology, but in general, if you have to take a decision, do you look at the person first, like the anthropometry, or is it the team that decides?
Actually, we look at all aspects, sir. Number one is how motivated the mother is, number one. Okay. That plays a very important role. That is when they come to you early, they comply with you, they are very willing to do everything. Okay. They facilitate their own well being, That is one. There are very many mothers we see who are high BMI who think they can't, but they have beautiful vaginal births because they are actually more flexible than I think low BMI mothers, to be honest.
Right, right.
Except for their, if their obstetric complications are not there, that is a separate entity altogether. There will be always need for obstetric interventions, emergency C-sections. We are not
Mhm.
interfering with that. We are only giving our biomechanical, a physiotherapeutic perspective as to, so let's say the mother comes with a like a discogenic problem. Now our goal
Mhm.
will be to do a detailed neurological examination.
Mhm.
Is the Romberg's positive? Is there any signs of cord compression? Is there any motor deficit, sensory examination, reflexes? You're going to look at all those aspects. Is there before you actually, how is their bladder and bowel control? You're going to look at all of that, rule that out, whether they are any acute, those kind of things, before you actually go in and say, see, there is no motor deficit, there is, the mother is willing, pain is
Right.
managed, biomechanically it's possible, functionally and positionally the mother is comfortable with all this. That is why it has to be practiced a few weeks before the EDD. When you
Right.
know all this is in place, then definitely you will have a good outcome for sure. So it
Right.
is important to have a follow up. It is important to discuss these things with the obstetrician, because we can't do independent work. The obstetricians have to support us, we have to support them, otherwise it will not work.
Right. So if you mention five things that you look in the person before deciding the position,
Mhm.
would it also involve investigations?
Definitely, sir. There are a lot of, some of them who will go to an orthopedician first and say, like the pot spine case, she was so keen because she's a young student mother. She was very keen that she has a vaginal birth. She finished her medication. She went, her orthopedician said, of course, you can go ahead. I don't think you'll have any issues. When they get that go ahead from an orthopedician or a neurologist, definitely
Right.
they will be more confident in trusting whatever you can give them. It also,
Right.
so if I have to say, referral system also is important, getting another opinion. And like the mother with severe vitamin D deficiencies, if she's having excruciating pain and we only look at pain relief and not look at compensating with her nutritional deficiencies, then her pain outcome will still not be very drastically different also, right? So it
Mhm.
is a collaborative work, I feel, and it
Okay.
is multiple systems which are important.
Yeah,
In
just one more thing. I wanted to know, like, you have a setup where these things are practiced,
Mhm.
and you have equipments to practice with and make the patient aware of such positions. But
Yes,
most of the birthings take place in low resource settings
yes,
and out of cities. So
yes.
I don't think that there will be availability of birthing balls, peanut balls, rebozos, and things
Doesn't
like that.
hmm. Doesn't matter, sir. I have gone to hospitals which are missionary run, where they don't have fundings and yet taught about upright positions. Okay, so you can have just pillows. You don't need anything else. You can get a
Okay.
cotton sari cloth as a rebozo. You don't need fancy rebozos. We use our cotton acha dupatta, na. We use that as a
Right.
rebozo to retrain the mother in
Right.
antenatal.
So
We
we
use
have
multiple,
options.
yeah, we have options. You don't
Right.
need a big investment. It is only it's really, you don't need a big investment. If there's no hydrotherapy pool, you can use a warm compress, a kapda and warm water, and put
Hmm.
warm compress to the perineum to relax the
Hmm.
perineum while birthing the baby, to relax the pelvic floor. All
Hmm.
these are very economical, no investment strategies, mechanisms that can be used as tools to support
Right.
what you are doing. We really don't need high investment at all.
Right, right. Thank you, Latha, for sharing this wonderful piece of information. And I think it is a step towards reducing uh, that fear of birth. And I think even infant mortality and the complications in the intrapartum and the postpartum period. So thank you so much for sharing this information. And I think a lot of physiotherapists must listen to this and gain an insight into what new intrapartum approaches are there and where our role and scope expands more. Uh, any advice you want to give to the therapists
Yes, sir, I can. Yes, yes. Thanks for asking
if
me
they
that.
have to choose this field, and why should what is in future for them?
Okay. The future is very good, I would think, because the scope of expanding your practice is a lot in this area. I feel every other area which are traditionally we do opt for. I think there are definitely pros and cons to every option, but I feel personally, women and babies, if you are influencing them and their outcome, in terms of emotional, in terms of physical well-being, in terms of birth experience, in terms of quality, in changing their outlook towards their experience, I
Right.
think that is a big takeaway. Like, when I was telling somebody my birth story,
Hmm.
first I had two vaginal births. First one was absolutely medicated on the bed, legs out throughout my labor. Second one was like with alternate birth positions and whatever,
Okay.
without any intervention. So when I
Right.
was telling them that, they were like, "Oh, it would have been very traumatic and painful." I said, I think it was beautiful. I
Mm.
think the first one was more helpless,
Right.
where I didn't
Right.
know,
Right.
everything was in other people's control.
Right.
So it is
Right.
about just the perspective. And if you can influence a mother to know that birth is positive and not
Right.
traumatic and painful, then I think the takeaway for a lot of women, and the women are the root of all, I think the population, the,
Right.
reproduction, everything, right?
Right.
So I
Right.
think that is a big contribution, and there is a lot of scope in this area. Please do
Right.
not think it is limited. It is a lot of scope. We can do a lot of research. There's a lot of area for research as well, which we should be doing, which we are
Hmm.
not. So we should. So in all those areas, I think it is, and even opening a wider perspective to even obstetricians, to care providers, is important, because I know not everyone has this kind of support that we have at Fernandez Foundation, and I'm very
Hmm.
grateful for that.
Right.
But I
Right.
think that should be universally practiced, and
Right.
yeah.
Yes. So I think changes should be brought in, and
Yes.
thank you. Thank you
Thank
so
you so
much.
much. Thank you so much, sir.